I've done hair transplant
or ecology as well. So this is my team international implant master.
So the topic
for today's webinar is
change is the
change is the key to success.
a new
A new revolution in implants.
So
whenever we think beyond imagination, when we think beyond horizon, we always find something new is coming. Be it automotive, every year there are so many new cars being launched. There are so many new electronic devices being launched. The moment you buy a new mobile, be it of any brand, the next month or something.
So change is a continuous process. If we will not change, we will be Nokia out of the market. So this is something which we need to upgrade every now and then. We should always upgrade our skills. We should always welcome what is changing in the world. So we as a dentist need a lot of more of improvements and changes in our dental practice. I hope everybody is listening and concentrating. So what's the change? We just need to think, what is the change? What we are going to talk about? So the first change is the change in the vision. So when the vision changes, your future changes, your success changes, you achieve new goals, you achieve new growth, new creativity, and you always welcome new innovations. So the next change is from change of the vision, I would definitely like to add my journey with this system, with the vision which changes continuously. So I'm practicing since 2010, and once I became passionate, very much passionate about longitudinal treatments, and started searching for the innovations in endodontics. In college life, if you remember, in the era of 2010 or before, we were only taught about the hand files. These rotary systems were definitely there, but were introduced in the market later on. Then I came to know about endomotors and heat-treated files, and then came the blue nitride files, which were really a game changer. So there was a huge change in my practice and success of my business. After trying all 5 systems in market and working day and night for accuracy of my treatment, I felt stagnant. Something was stagnant. I was not like daily routine, you come and go with the same treatment line. And what about the other things? So stagnant to normal, which is now getting good. This changed my mind and vision, and I started searching for innovation from complete dentures. Earlier, I was like something I wanted to master, a science or good enough. Then I went to search for complete dentures. Attended to seminars and learned the methods of cutting impressions for both FPDs and CDs. It again changed the accuracy of my treatment. There was a huge, big change in dentistry which was rapidly changing the of orthodox dentistry. Orthodox dentistry is the RPD, the FPD. Something big was going behind our eyes. That was conventional implantology. Conventional implantology was simply a topic in our books. We were never taught about. We were never had any workshop. So after 4 or 5 years of our practice, I realized that something new is actually entering the market in the say patient's acceptance. So I also went this way. I learned conventional implantology and practiced it for many years. But it has its own flaws, which I suppose everybody would agree to. So the flaws of conventional implantology are failures, fractures, limitations in limitations in quadrant rehab, limitations in immediate rehab, requirement of 2 surgeries, waiting period of 3 months, and requirement of bone augmentation. See, we are all dependent on patients. So when a patient enters your clinic, he or she has not come for a date of 3 months or 6 months. He has come for the replacement of the tooth today. If there is something you can give today, patient is definitely ready to accept it. But if you say we will do 2 surgeries, we will wait for 3 months, patient needs time to think. He thinks I'm going to spend lakh, 2 lakh, 50,000, any amount the doctor is asking, but when I'm going to get my teeth. If you are in the market, say suppose purchasing for a television, and if we told you it's out of the stock, kindly wait for 50 days, will you wait? Money is in your hand, you're standing at the shop, kindly deliver it today. So all these limitations, I was also living with them, I was also working with them, I faced failures, I faced fractures, I faced limitations resolved with something. I always rejected the cases, kindly go to some other clinic, maybe more specialized person, I cannot handle it. Limitations in quadrant is something I always ask many colleagues, mentors about the quadrant react. If they have any answer, they say expect the remaining to do the full art. So limitations in immediate react, immediate जैसी कोई चीज ज़्यादा है नहीं conventional में, दो new methodologies are definitely upcoming, new designs of implants are definitely upcoming, but there is a difference. There is a difference, it can be loaded and it has to be loaded. So if the doctor is pressurizing a company says you can load in 14 days or 20 days, 21 days. But if you ask them, should we? They will say no. All the conventional plans should be left for 3 months for the period of integration and then they should be loaded. So this was the first change I realized, change in the technology, change in the mind, change in the vision. If you can visualize something beyond, you will definitely meet success. Second change which I applied in my practice was change in the implant system. So while I was after doing conventional implantology for many years, I found few of my friends and many people on social media who fascinated their pages with OPGs with 10 or more implants. I always thought this, we can do the thing in 6 implants. Is there really any need for going so much aggressive 10 or 12 implants? I always neglected the science, but as my social media or as my friends, they flourished all these media platforms with OPGs. Then I thought something is again really different is coming and we should be the first to accept it. So I really thought that there are up to when things can be done in 6 implants in each arch, then why so many implants are required? So I started searching texts and seminars over the same and came to know that a strong new revolution is knocking on the door of a new era of implantology, that is cortico-basal implantology. I attended workshops and learned this science and found it really helpful and game changer in immediate functional loading of all type of cases. Listen again, the word is immediate functional loading. This is not just placing caps over the implant system. This is functional. Patient has to eat. This is not can be done. This has to be done. So, immediate functional loading of all kinds of cases, be it single tooth replacement or quadrant replacement or full mouth or even failed cases. So I regularly get calls from my colleague doctors in my city or in other cities that this or that implant has failed. Can you please manage with your system? So this is the change. When you change the implant system, this is something again like changing your mobile phone, changing your new car. New car because it was purchased few years back and now it is old. New models are in the market. So the success which I have seen with cortico-basal implantology is tremendous. So I would like to show you a few glimpses of my journey with cortico-basal implantology, what it gains, a simple change in the implantology, how it can help us. So from RBG to OPG, most of the dentists say, more than 80% of dentists, if anybody of you is having a good practice, say urban practice or say good amount practice, then things may be different. You may be having these gadgets from the first day. But averagely from a dentist who has just risen from a say middle class or who is working hard for his own earning, this is a big dream turning your RBG machines to OPGs, getting from single small x-rays to full OPGs. There it's a better time of surgery. thing which I changed in my clinic was physical impressions long back in 2023 only. I purchased scanners, again a game changer in technology. The third thing which I thought is something should change again. When we have a scanner, we are always dependent on the lab to fabricate our prostheses or crowns. Then I came to know again something new is there which is known as printers, digital printers. I thought printers are for paper printing. How can we make processes? So this was again an eye-opening. I realized what we are doing, in which era we are working. Man, this is 2023, 24 and now 35. If we will not upgrade, we will be defeated by new generation scientists or say new innovations. We will be falling and knocking out of the market very soon. So I upgraded to digital scanners and printers, and now I can fabricate and deliver the processes within a day. Morning hours I do surgeries for mouth, art, whatever is required, and by evening I am giving them prosthesis in-house made. So the next change was I was having two dental chair practice, which very soon converted to 3 dental chair practices, and I am now planning to install my 4th dental chair because workload is really increasing. From 1 dental associate to 3 dental associates in my clinic is again something which shows yes, I am working. Some growth is really approaching me. From the 50 implants in 6 months in conventional implantology, we always purchase deals from various 2-piece implantology companies, and then we suppose place 40 out of 40, 4 or 5 fails. It again comes back to inventory. I again have 15 implants. I place 15, 2 fail, again inventory. It always took me many months to finish the inventory and pay them off. So the transition is from 50 implants in 6 months to reaching 200 implants per month. Yes, this month it's just 15 days of February and I have almost placed more than 100 implants. Considering 42 implants which I placed just before today means yesterday. For the past 3-4 days, morning and evening I am in the surgeries. So this is a very big transition, very big change in my life. 15 implants to 200 implants per month. The next thing which I achieved was changing this sedan to XUV. Again, something very big dream. I will still say I will leave those people who may afford it on the day one, but people who cannot afford working day and night for the livelihood of their families, it's a big dream to achieve. Nowadays, we are working with these taglines from no teeth to fixed teeth in just 1 day, which is implant supported, no incision, no suture, and we deliver same day implant and teeth, which is really gaining popularity and more of the patients to me. Again, something changed. The change is social media. We design these type of posters and we fly them on the social media, the Instagram or Facebook, my clinic page, my personal page. All those who are going to me in my Facebook or my Instagram must have definitely seen this thing. So again, it's a change. If we will not enter, we will not accept this change, again we will be out of the market. So, what are the benefits of cortico-basal implants? Immediate functional loading. Patient has come to your clinic not for a waiting period. वो एक हिंदी में डायलॉग है ना, तारीख पे तारीख तारीख पे तारीख. तारीख नहीं देनी है यहाँ पे. We need to actually work on. The case which I did day before yesterday, quadrant case, yesterday only we have definitely delivered processes to them. So the patient might be having pain. Okay, pain is a part of the surgery. It has to be there for 7 days. But he is at least having a justification. He gave me some money and he's actually having teeth in his mouth. He can actually chew. So single surgery required, no incision. It's completely flapless, no sutures. So sutures are something now left in my inventory only for third model or surgical extraction. It saves money. It saves effort. No bone augmentation. Bone augmentation is something which is a move to conventional cardiology, but do you actually think something is incorporated in your body which needs to resolve? Your body has to do so much extra work to convert it to actual body cells, which is your osteoblast, which is really a very big task to our body. So we should actually avoid bone augmentation. In the conventional practice also, a jumping distance of say 2, 3 mm, 4 mm doesn't require any bone augmentation. So in my practice of conventional also, I left bone augmentation long before, and in basal cardiology you will never ever need bone augmentation. No repeating patient visits. Today we are going to do this trial, today we are going to do this and that, every time opening the screws and placing the jabber forward, opening the jabber forward, placing the screws, patient is screaming every time. I really think everybody will appreciate this point because this is something which we have all practiced. Patients' ears are something which breaks us. So no peri-implantitis because it's a smooth surface implant. It's very hard for pedicle formation. It's very hard for colonization of bacteria. It can be placed trans and is the only system we can use to reach the bone trans sinus because the smooth surface, even if there is a case of sinusitis, so bacteria will not colonize on this implant. Conventional implants are never meant to go trans sinus due to retrograde infections. Minimal complications in diabetics, smokers, anticoagulants, cardiac patients, dialysis patients, cancer patients. This is not just a line. I have treated all of them. And not one or two patients, many of them. I did cases for dialysis patients who was on dialysis twice weekly. Beautiful case. Highly resolved rich, many hoops come present, but a beautiful case with good success. Cardiac patients, it's always been a known fact that cardiac problems of say more than 6 months or 1 year are always ready for the treatment. Anticoagulants, if suppose somebody has not informed you about anticoagulants, still you are not raising the flap. The excessive bleeding is when you raise the flaps because blood circulation is in the flap, in the soft tissue, in the gingiva, in your periodontium. So when you are not cutting it, so there will be very less blood. Diabetes, I have done cases as high as up to 12 HbA1c, 7 and 8 HbA1c is a regular finding in the clinics and we regular to patients without any ever failure. All these things is something which is documented in me, which is in my data. All the OPGs, all the patients record and the testimony in my data. Anybody can ask any time regarding diabetes also, regarding dialysis also. So the next big change is our target bone. So when we see we have changed the implant system, we have changed everything. So something still needs to be changed. That is our target bone. If you realize we have a tooth structure, then there is an alveolar socket. Below alveolar socket there is spongy bone, and then comes the basal bone. A word which is very much untouched, basal bone. It is not even covered in the texts of colleges. We never studied about basal bone, what kind of bone morphology it is having. Maybe OSMF people may have studied, but as in the curriculum of general BDS, it was not emphasized. So basal bone is something which is our skeletal bone. It is something like which supports our skeleton, our muscles, our nervous system, our everything. So that is the basal bone. This basal bone is supporting our teeth in case of our maxilla and mandible. So this is, as you see in the diagram, the area which is just adjacent to your dentition is your cortical plate, or we say it's alveolar socket. Two kinds of alveolar plates are there. One is the buccal alveolar plate, second is the lingual or palatal alveolar plate. You ever realized how much hardness this alveolar socket has? We have to apply so much pressure to luxate our tooth. Why? Because the alveolar processes are cortical. They may have a very dense bone. But as soon as you try to place an implant in a conventional method, the moment you drill 2 to 3 mm beyond apex, you find a very soft bone. The bone enters just in a say jerk. So why? The alveolar process was so much hard. then why the surrounding tissue so much soft? Because that is known as the spongy bone. The spongy bone gives cushion to your bone, it supplies blood vessels to your bone. Below that, you can say whenever you reach 4 to 5 mm below the apex of a tooth, we get a very hard bone. We find good resistance. That is the reason. So when we change the target of our implants, things may change. So in conventional implantology, implants are anchored in only one cortex and engaged in soft spongy bone. So whatever torque, say 30, 40, 50 you achieve in conventional implantology is not from the center of the bone, it's just from the crest of the bone. As soon as you submerge your implant 2 to 3 mm below apex or below crest, you will find your implant silently getting loose. It actually starts rotating. Why? Because there is spongy bone, there is no hardness in that bone. So the support which conventional implants take is from the first particle. Finding hard even bone and achieving very good stability in many times, in many cases with true piece implantology or the bulky implants is very difficult. Everybody would have faced this difference with this problem. So just think, how about imaging a bone beyond our vision? We cannot see the visual bone actually. We can see the sponge bone, we can feel the sponge bone, we can explore the sponge bone with any of our instruments. But visual bone is still deep situated. So just think beyond imagination which we cannot see, which is rich in hard lamellar bone, has less vascularity and not prone to desorption. Yes, that is our basal bone. Basal bone never resolves. Why? When everything is resolving, you have seen resolved maxilla, you have seen resolved curiosity, resolved buccal plate. Okay, few things are constant. They never change. They never resolve. Or even if they resolve to a certain level. That is our basal bone. So what are the common basal bones? You say your myloid ridge is a strong basal bone because it is giving attachment to muscles. And this is your base of the mandible. Base of the mandible, this is something like supporting the entire mandible. Base of the maxilla comprised of your nasal floor and palate. Just imagine if they will resolve, how will you breathe? If your nasal floor will resolve or it may have a same fracture, how will you breathe? How will you inhale? So these are the basal bones which are not going to resolve any time of your age. They may weaken but they will not resolve. Crest and basal implants. So conventional implants are very often do not have adequate bone for their placement and will very often need bone augmentation grafting for their placement. Basal implants take support from the available basal bone. So in this thing we say the lesser the bone, the better the case. But it's reverse. For conventional we have lot of bone, but in the basal we say lesser the bone, we are more happy. So if you see this diagrammatic presentation, your conventional implant has somewhere say seated in your spongy bone, but your basal bone starts from where it ends. So this is your basal bone. If you just imagine without dentition, a resolved kind of bone, this is only the pure basal bone, pure D1 bone. So benefits of basal bone. It is relatively fixed and unchangeable framework of the mandible and maxilla. It is present throughout life and is strong, its stress-bearing part of our skeleton. It is highly corticated and dense in nature. It has less vascularity, hence can be used to treat diabetic patients and smokers. Have you ever read what is the problem with the smokers? Why smokers are contraindicated or say we should check our line of treatment with conventional implantology? Because in smoker, micro blood capillaries are burnt out. And when we are working on implantology, we need moisture, we need blood supply. In smokers, since the bone is very much brittle, the bone lacks the adequate amount of blood supply. So it becomes difficult for implant to start authentication on time in smokers. When our target bone is changed, we are targeting a bone which already has a less vascularity but very dense. So this problem is avoided. We can very well work in cases of smoking and patient on diabetes. It is highly mineralized and less prone to resorption, I just explained to you, because it is supported by muscles of mastication which provide functional growth to bone. There is less spread of infection with second cortical bone. Have you ever seen any periapical abscess perforating your second cortical? Just imagine a very big periapical infection over say 1-3 maxillary canine. Big infection. You expected, you scooped out everything, but they did enter the nasal floor. Did your instrument reach the nasal floor? No. Because it is so much dense and less circulation that the infection is limited just beyond it. It will never reach beyond it. It is always beneath the second cortical. Take this point. You will never find any infection possible myloid ridge. Not possible. So the next very change which I found, which we can say is the innovation, the main theme of my lecture after change is innovation. So change is the design of implant. We change the system, we change the mode, we change our vision. But something is still lacking. What is lacking is the change in the design of implant, which is a real innovation. After studying all the texts regarding cortico-basal implantology, I came to know cortico-basal implantology has been practiced in Europe, say, since 1970s, but never gained that kind of attention or success like the conventional implantology booms to. So people over there were definitely in a research, in a development, in a innovation, in the change in the design, and making others realize that something should be changed. We should be accepting new normals. So the next change is the change in the design of implant. Just imagine body of a conventional implant. Do I have a slide? Yes, I do have a slide. Just imagine the body of this conventional implant. It is having its maximum diameter, which is usually 3.75 or 4.2, 4.55 at its cervical area. So where does this cervical area sit? This cervical area sit in the narrow alveolar socket or crest of our bone. So it is broad at the cervical area of the body and tapered towards the apex, while our bone, which is broader at the base. Just imagine, you have always seen CBCTs of sections of our bone, and we have studied in anatomy. So kindly just imagine every bone is broad at the base. If it's maxilla, it gets broader as it reaches your palate and nasal floor. And if it's mandible, it again increases the width as it reaches your basal bone, here this base of the mandible. Then why do we have a design which is broad at the say cervical area, at the area from where it has to enter, the first cortical, which is already thin? That is due to this wire channel. If this wire channel is avoided, this implant can be streamlined, this implant can be narrowed, the size, the bulk of this implant can be reduced. So one piece, single piece implants definitely have better, biological bone widths are better maintained with single piece implants. But the problem which earlier, many companies had one piece conventional implant also. But what was the problem? The problem was you cannot bend them, you cannot change their angulation. If you cannot change their angulation, how will you place your crowns if your implant is little bit tilted? So we as a practitioners avoided using single piece implants. And what about delayed healing? These implants are meant for delayed healing. If you place a single piece conventional implant, it has to be loaded because it will emerge out of your gingiva and patient will definitely eat from it. It will lead to failure. So something needs to be changed. So maintaining the biological width of 2 mm, say buccally, lingually, palatally, becomes very difficult with such kind of design. If it is bulk 3.75, 4.2 mm at the cervical area, How will you actually manage your 2 mm biological width? While in this cortical implantology, if you see the design, this part is a shaft, the central part, upper is abutment, lower are the blades. This shaft is just 2 mm. This is just, say, reverse to the design of your conventional implant. This shaft is 2 mm and this is what emerges out of your crest of your thin alveolar bone, which becomes more thinner, more resorption after extraction. Just 2 mm. So even if you are having a bone of say 4 mm at the crest level and this shaft is just 2 mm, you still have 1 mm both sides. How about placing a 3.75 implant when you have a crestal bone of 4 mm, 5 mm? Ridge split, what will you do? Ridge split, densa. How much will you expend? Say 1 mm, say 2 mm. How about changing the design of the implant and taking an implant which is having a shaft of just 2 mm, which naturally maintains the biological width of buccal and the lever plates. Then comes the blades. So the maximum diameter which we have 3.5 or 4.5 of a basal implant comes at this level, which is your blades level. And where are these blades seated? These blades are seated deep in the basal bone, be it maxilla or be it mandible. They are seated deep in the maxilla. Yesterday only I did a very resolved case. So it was something like knife edge ridge in maxilla and mandible. So with the puncture of first drill, we were definitely thinking, will this implant enter? Definitely not the conventional one, but this cortical implant. So as soon as we felt or palpated the base of the mandible, oh my God, there was too much bone. So the doctor called me for a highly resolved ridge and I could found so much bone beneath the crest that I placed 3.5 mm implant completely submerged in the bone, just 2 mm shaft coming out of it. So all the theories of remaining bone width are fulfilled with this kind of design and implant is in good harmony with the bone. We have always seen CBCT and we plan CBCT or this is the era of say guided surgeries in conventional implantology. So we always see such kind of images. So when the tooth is in a good health, bone width is this much. Teeth are mostly present in the buccal part of your alveolar socket, alveolus, and there is less of the buccal bone, more of the parietal. So we need to change our vision, our target bone and our target implant. When you place a conventional implant, just imagine having this bulge at an area which is already resolved. Now how will we achieve the biological width? We will submerge it. When we will feel there is deficiency of buccal bone, we will submerge it more further. How much further? Sooner or later, after 3 months, you realize now we need extra long gingival former. Then we call the company people, my implant is deep seated, kindly give me a gingival former of 5 to 6 mm. Do you really think getting a loosening device at a depth of 5 to 6 mm is worthy? Implant should be just 2 to 3 mm below the crest, adding 2 mm of gingiva. That's it. It should not be beyond. But to maintain the biological width, we have to submerge this implant a lot. Now just change your vision again. Just see the design of this implant, this basal implant. Where are the blades? Where is the maximum thickness of 3.5 mm? It's in the basal bone. It's in the soft bone. Part of it's in the soft bone, part of it in the basal bone. It's deep in the bone. There is lot of bone both sides. Same design, same diagram to represent something. What is coming out is just shaft. Only the shaft is coming out in the area which is highly resolved. This base is quite broad and this is where my tip is landing in the nasal flow. This is your nasal flow. My tip is landing in the nasal flow. For what do we call it? This is osteofixation. This implant is fixed in a bone which is very much dense. So osseointegration will have time to take its course. We are not dependent on osseointegration at the early stage. We have achieved osteofixation. So how about changing the design which is which is compatible with a dense bone, with which we can achieve also fixation. Osseointegration is a property of titanium. Please, everybody, do not ask this question whether they will osseointegrate. It's a property of titanium. It's not iron or steel. If conventional implant is a titanium, then this implant is also titanium. Both the implants are meant to osseointegrate sooner or later. Few days maybe early or few days maybe late, but they have to osseointegrate. So what's the next change? Are we over with the changes? No, we are not over with the changes. We are in an era which is continuously changing. We need to move. So the next change is a change in the implant practice. After this webinar, if you are not taking this implantology regularly in your practice, think twice. You can contact me, you can ask yourself, you can ask your seniors, other mentors, anybody in the universe. If one can grow, the other cannot. Why cannot we grow? We all should grow. So there is a big boom, big change in my implant practice. See, with all the previous changes which I have shown you earlier, change in vision, bone, implant, your mindset, everything changes. Your dental practice definitely changes. You can touch a new sky of infinite work, success. How? I will show you. Just look at these cases, just count the number of cases. A highly resolved ridge, highly resolved full mouth case, done with cortico-basal implants. Again, quadrants, patient having multiple missing teeth, few fractured, upper sevens are fractured. How nicely we manage this case with cortico-basal implant. This is a third case, a rapid fire round case. Patient entered my clinic. I am having bilateral missing teeth. I visited certain dentists. They told me about Ostem and other brands of conventional implantology, which I should go. They are saying it's a waiting period of 3 to 4 months. I made them comfortable with the thing that I can give you teeth in 3 days. So rapid fire round case completed in 3 days. The fourth case is Mr. Pradeep having a quadrant failure. We removed immediate extraction, immediate loading and immediate functional loading also. This is the next case. All the upper teeth were somehow fractured or cariously decayed. It was a visit case. So as per the orders of the clinician, I removed all the 14 teeth, placed all the implants in the upper arch and restored the same with my digital scanner and digital printer same day evening. Patient was very happy spending lakhs on this. So again a full mouth case, though bone was sufficient in the mandible, but how would I manage this expanded sinus case? All on 4, all on 6. All on 6 would have been difficult, all on 4 case. All on 4 is having its own merits and demerits, everybody knows. So it's another case, Anita Devi, we have done upper and lower both the jaws with cortico-basal. This is yet another case. The quadrant, you can see the highly rheumatized sinus, but still we managed this very nicely with cortico-basal implants. Again the next case, lower quadrant, patient was in a dilemma since year or 2 years whether I should go for it, I should not go for it. Everybody says इसमें time बहुत लगता है, but we restored in just 3 days. Again a next case, full mouth case, extractions. Now why I have shown you all these slides? This is not a webinar for showcasing what I can do or what I have done. This is what I have achieved. These last 10 slides or 10 cases are just 10 cases which I did in January only. Only in January these 10 cases are few of the cases which are documented completely in my mobile phone. I can show you. So just imagine the amount of work, the amount of implant consumption and the amount of revenue which I would have generated. So this is nothing to say be proud of. This is definitely to be proud of. This is something eye-opener for you. All the people attending this webinar, it's an eye-opener for you. If we can do it, my team can do it, I can do it, you can also do it. I am placing more than 200 implants per month, cortico-basal implants. And we as a team are placing more than, say, around 1000 implants a month. This is new era of dentistry. I want all of you to wake up, to come to the next level, achieve your dreams. Have you ever seen your old friend, schoolmate coming to you and telling you, I am a software engineer, I am settled in US or say Singapore or say in Hyderabad, I am having a salary of say 3 to 4 lakhs per month, a package of 30 lakhs, 40 lakhs. Arey yaar. Show off. Why so much of show off? No. It's a value of their degree. It's a value of their hard work. Are we not hardworking? Doesn't our degree allow us to earn this much? But how? See, after getting our degrees, it takes much time of 4 to 5 years to let the city know we are dentists. Then it takes another 5 years to master the science which we fail to do in college life. After 10 years, our real practice starts. But on the other hand, a friend who was a CA or a friend who was an engineer, they suddenly rise to their heights in that 10 years from a job of 20,000 to 20 lakhs or 30 lakhs in just 5 years, 10 years. They are having good cars, they are having good mobiles. Isn't it fascinating? Where are we standing? Shouldn't we work hard for this thing? Yes, we should definitely work hard. So when my team showed me this way and I joined their this path of progress, I attained something which is restlessness. I am having work day and night, I am working day and night, I am traveling day and night for the work, I am getting regular consultations. I never consulted for a RCT or conventional implantology in my entire career. And now daily I am somewhere at some other clinic working day and night for this system. So this is the next change, the next eye opener which everybody should look on to. When you also can just wake up and start moving. So welcome to the success, enjoy the journey. These are a few of our upcoming courses, and this is 2 days orientation program being planned in Hapur or Ghaziabad on 1st and 2nd March 2025. Then is the next big thing, the next very, very big thing in our academy, International Implant Master Academy, which is our international fellowship in cortico-basal implantology. And this is scheduled in Philippines, Manila, in the month of April, 10th to 15th April. And again, a game-changing phenomenon, much beyond attending normal conferences, going to some different countries, being financed by some company and just enjoying your everything and coming back. How about getting a degree? How about getting a fellowship in some other country? It's Philippines this time, and we have targets some other countries also. So again, something we are looking for. We are very much excited for this event in the month of April. The next course is PG Diploma in cortico-basal implantology, which is scheduled to be held in Ghaziabad, only in my city, in my center, in the month of April, in the last days of April, say Thursday, Friday, Saturday, Sunday of the last April. So this will be again a big event, big change in the life, because this is not a just certification program. Most of the courses run India-wide are just certificate programs. This is PG Diploma by Education Board, London. So this is again a big event coming in April. Kindly stay tuned and do register if you want to learn this science. These are few glimpses of our past courses held at my clinic, at Chandigarh, at Delhi, Bangalore, Kotur, Lucknow. Different places, different people. We have met so many mentors, candidates, doctors, seniors, juniors while traveling all the India or worldwide. Madhya Pradesh we have been to Rajasthan, we have been to every state working with this thing. So very happy faces. Most of them are working very good in their cortico-basal implantology system at their clinics. This is my lecture in World Dental Conference Bali in December 24. The next image is my award being presented by Mr. Ravi Kishan, actor of अब तो बहुत सारे awards में आ गए, बॉलीवुड में भी हैं और भोजपुरी में भी हैं. So it was awarded by Dashna Foundation Delhi. Heartfelt thankful to the foundation. So this is the end of today's webinar. I hope I didn't waste your time. I hope everybody would have taken few catchy points which you can incorporate in your practice. I will be definitely coming up with some new topics, some good topics, more depth over the topic of cortico-basal implantology in my future webinars. I will be definitely looking for something which we say as a supportive programs, orientation programs, and collaboration programs in your cities, in your taking workshops in your cities. So thankful to all of you. I thank all the people here to give me time to attend my seminar. I'm a fast speaker, I think. We finished it a few minutes before. If anybody has any questions or doubts, so if you want to discuss, you can. How will you listen to this? If anybody has any doubt or anybody has any questions, we are open. The house is open for the questions.